Reduction of red blood cell transfusions. I want to remind you that after this panel, we're going to have a breakout session, and there we're going to review the recipes that these different experts have come up with. Our moderator, I'm going to introduce each person and ask them to come up. I'm going to do all 6 this time. Our moderator is Dr. AWadhi. Dr. Shander is a clinical professor of anesthesiology, medicine, and surgery at the Mount Sinai School of Medicine and the head of anesthesia at Englewood Hospital. Dr. Shander.
Thank you.
Our first panelist, I think you know pretty well by now, is Chuck Denham. He's the chairman of the Texas Medical Institute of Technology and the chairman for Global Patient Safety Forum. Thanks, Chuck. Our next panelist is from Yale University, Keith Ruskin. He's a professor of anesthesiology and neurosurgery. Keith. Somebody counting the panelists for me so I can. Our next guest is Michael Henderson. He's the Chief Quality Officer from the Cleveland Clinic Health Foundation. Dr. Henderson. The next panelist is somebody who's very important to me because he taught me how to be an anesthesiologist. He's the chairman of anesthesiology at the University of Vermont, Howard Shapiro. If it wasn't for you, I wouldn't be here. Our next panelist is the professor and chairman in the Department of Anesthesiology and Critical Care Medicine and the vice president and the executive medical director for Johns Hopkins International, John Ulatowski. Our next guest came here from Cairo, Egypt, so hopefully he's adjusted to the time zone and so forth. Dr. Whalea AWadhi, he's assistant lecturer of neurosurgical anesthesia, and he's, as I said, he's on the medical faculty of Cairo University. Our next panelist is Tim Goodnow. He's a professor of medicine at Stanford and the director of transfusion services at the Stanford Medical Center. Dr. Goodnow, thank you for coming. Okay, is there anybody left standing over there? I'm never, ever going to live this down. So red blood cell transfusion is the most frequent procedure performed in U.S. hospitals today, with 1 in 10 patients receiving 1 or more units of blood. Red cell transfusion practices are highly variable by institution, procedure, and physician. Evidence from observational studies show that red blood cell transfusions can increase morbidity and mortality by up to 88%, while restrictive blood transfusion practices have shown in multiple randomized trials to be safe. So our panel is going to address some of these issues, and we look forward to hearing what you have to say.
Do you want to give the talk, Mike? I mean,
no.
And by the way, there's 8 of us, not 7.
Okay.
So that's good.
Okay. Well, I didn't count you, Area, because there's a...
Well, thank you, Michael, for a wonderful introduction. And clearly, it's an honor for me to share the stage with this tremendous panel that's to my right. I do want to take just a couple of minutes to thank Joe for the vision and organization, for Michael to add levity to a serious topic, and clearly the people you don't see, Paul Jensen, who's been working on every detail, and all the other people behind us working as a team to produce this. This is the way we deliver medicine, and this is the way we deliver a vision. So again, thank you very much. I also want to say that when Joe said that people came from all over, he failed to mention New Jersey, where I'm from, probably for good reason. But New Jersey has been in the business of patient safety, especially in anesthesiology, for over 40 years, with Irv Moss being, again, a leader. So keep in mind that this journey of patient safety will never, ever end. This is something that we're going to scale for years to come, because when we solve one problem, another one rises. So again, keep in mind that we need to transfer this vision to the next generations, not leave it here, but again, make sure it stays alive forever. Now, I did come from New Jersey, and I came from the airport. And I actually rented a car with permission, and I used the GPS to get here. Again, it's not a monitor. It actually helped me in decision making. Where I didn't know where I was going, a voice came on. Wouldn't that be nice that when I made a mistake, they kept me back on track? Wouldn't that be nice to have that in a hospital? decision-making or, again, tools to help us make decisions. And when we veer from the track or the goal of the therapy or treatment of a patient, something brings us back to the center so we don't, again, get confused or distracted. I think, again, monitors, if you look at them, are basically nouns. The only adjective I know for monitor is checking things out. Communication is very important. We already discussed that. So keep in mind that we need to change some of the language. We're looking for something that could do more than just monitoring. We need something that can actually oversee, overlook, and keep us on track without distractions. The problem, again, are the barriers. And one of the barriers, of course, is the priority that we have as a society. Again, we talked about medical errors, but what about your neighborhoods when there are people dying in intersections? The cost is always the issue. Well, we can't put lights up because it's too costly for the town. But when somebody as a hero takes a trip across the Pacific or across the Atlantic in a single boat, okay, trying to, again, do the journey of Contiki or some other vessel, and they get stranded in the middle of the ocean, that person gets aircrafts, boats. The governments have no stop in terms of the amount of money and resource they'll use to get this person out. We need to change our priorities. And again, I think that keep in mind that with medical errors that we talk about, there's no intent. But I think another barrier is ignorance, which we'll address with you today. So with that, we'll move to the first slide. And I just wanted to tell you that the Joint Commission and the AMA, the PCPI, again had a national summit on overuse in multiple areas, of which 5 were chosen. One of them was overuse of red cells. And this is the Physician Consortium for Performance Improvement of the AMA. And you can see this was pretty recent in September of 2012. The representation here is not just the blood industry, but also professional organizations. So you have the providers of blood and the users of blood, but everything concentrated around the safety of blood versus the safety of the patient. We need to move away from a product-centered thought in terms of how we deliver care in transfusion medicine to the patient and not, again, think just about the product. So why do we need a consensus on overuse in red cells especially? And I'm not going to address the other areas that we talked about. Already mentioned by Mike is the fact that you could see that transfusions are on the increase. And again, there are different areas where a lot of blood is being used. And the question, of course, is how much of that can be avoided, especially with the fact that the benefit-risk ratio is not favorable in many situations. You could see that in U.S. hospital, discharges of blood transfusion procedures per year, you could see that 1 of 10 of all hospital stays had a procedure. Again, there was a transfusion involved, and the cumulative growth of 140% from 1997. This is one of the fastest growing top 5 procedures, a very common procedure. But you'll see why we need to address this in a few minutes. So again, although we know that blood transfusions may save a life, but in fact we have to stop the bleeding too. As I tell my trauma surgeons, if blood could just save a life, we wouldn't need you. You also need to stop the bleeding. Again, but they do carry adverse events as well as risk, which range from anything from fever to worse patient outcomes, including death. There's variability in clinician practice. We've heard variability amongst hospitals when it comes to medications and others. We have the same problem when it comes to transfusion. And these lead to inappropriate blood components and proper use of patient blood management. We have other ways of dealing with this, again, by avoiding transfusion or reducing patients' exposure to allogeneic blood, have already been tested in a few hospitals and actually deliver not only reduction in cost and utilization of resources, but also improve patient outcome. The scope of the working group was to review, again, as what we did in the summit, patient blood management or PBM strategies that, again, can be implemented and can be implemented easily and already have been implemented. Let me just take you back to the definition of patient blood management. This is the timely application of evidence-based medical and surgical concepts which are designed to manage anemia. There is a disease-centered approach. Optimize hemostasis and minimize blood loss, as well as blood transfusion, in order to improve patient outcome. We've moved from blood safety to patient outcome and patient safety. If you saw on the bottom of the slide, this is a multimodality approach. Medicine is not an individual sport. It is a team sport, and we keep forgetting that on a daily basis. So now let's take a step back and see the amount of actual education that physicians get in medical school when it comes to one of the most common procedures done on hospitalized patients. So this is Julie Karp's work, again, when she was in Baltimore, looking at transfusion medicine education undergraduate medical schools. And again, I already mentioned to you where transfusion lie in terms of a common procedure. These were 86 American medical schools, 83 administrators, which are deans or the ones who are actually involved in teaching, had the response, which is a very good response. And about 50% of the medical schools reported 1 to 2 hours of the 4 years of medical school educating the physicians in terms of transfusion. And most of that had to do probably with ABO compatibility. Again, 92% of the teachers were unfamiliar with the 1989 or the 1995 Transfusion Medicine Academic Awards, which is the curricula which is, again, developed for education. So again, you could see that this could lead to extreme variability in transfusion, one of the issues we talked about, little to no evidence practice, a lot of behavior, and again, overuse. A little knowledge creates fear because we as physicians are fear averse. We are averse in terms of risk aversion, not to the patient, to us. So again, we look to others to teach us how to deal with this, and you could see that we're learning behavior rather than science from our predecessors. None of this would be an issue if red cell transfusion had no risks. Again, a very poor risk to benefit ratio in many situations. They have adverse clinical outcomes that have been repeatedly, again, published. There's inventory pressure at times. Again, if overuse is one of the issues, again, when we have shortages, can we again overcome them with control of the overuse of red cells? And of course, there's enormous cost to healthcare and society, which I'll address with you in a minute. So this is just a list of some of the RBC transfusions that have been the risks associated with allogeneic transfusion. You could see them on the slide, and there's another even more robust risk in terms of the adverse events. The issue, of course, is where is the benefit and how we measure that. Now, the problem is that the naysayers say, well, these are all associated risks because most of the trials, if not many of them, are either retrospective or observational. Well, keep in mind that the causality of smoking and lung cancer is based on this particular principle, a Cox postulate, which again can be expanded. And this is an article that actually ties transfusion of red cells to, again, some of these risks that were described. So to quote Bruce Spies, who's in the audience today, in his article, Risks of Transfusion Outcome Focus, there are few, if any, articles that support transfusion actually improves patient outcome. But patient outcome is only one issue because we measure outcomes in terms of survival. Health actually is well-being. So we need to look at the total picture of not just survival, but patients, again, having well-being. And he says, again, the majority of database papers show association between transfusion utilization and immunosuppression, increased infection, renal failure, multisystem organ failure, and of course, we mentioned already death. So we have looked at some of these issues in terms of pressure. This slide is just to demonstrate to you between the amount of blood donated in blue and the amount actually of blood being transfused in red. You could see that no matter where you are in the Western world, the margin is so small that pressure on inventory is always there. But nobody talks about controlling the overuse, which again will make this a larger margin. The other question, of course, is what's pushing it? Why is that such a narrow margin? And that's a question we're not going to be able to answer today. So we set, and some of the people sitting on the panel, we set out to ask the question, not necessarily the appropriateness of transfusion in terms of definition of whether it was the right thing to do or not. We defined appropriateness as improving the well-being of a patient, the patient's health. And again, we looked at 450 clinical scenarios of non-hemorrhaging, stabilized patients who received transfusion, the large majority of patients in this country and most of the Western world receiving between 1 and 3 units of blood. And what we looked at is to see whether they actually impacted negatively on patients' health, inappropriate in red, or whether we couldn't actually look at the benefit. So in the absence of benefit, all we're giving patients is risk. And of course, the last is that transfusion actually improved the health of the patient. And you could see from this slide that only 12% actually improved well-being or health of patients. Somewhere between 60 to up to 80% not only had no benefit, but actually represent a risk to the patients. The costs, the barrier, one of the biggest barriers every time we want to improve patient safety is cost. Why doesn't anyone stop and ask the patients what they want? If we went to the public, what would they tell us about where we want to spend our money? Well, in fact, we know that buying blood is a small portion of the cost of transfusion. In the United States, it's about 3.5 to 4.5 times of the cost of purchasing blood from the blood bank. We're talking about enormous amount of utilization which can be controlled, and these resources can move into the areas of patient safety that we are so concerned with. And this, again, is Morton's data looking at the frequency and outcome of blood products transfusion across procedures in clinical conditions which warrant inpatient care. And this was an analysis that was done in 2004, but we don't have any newer data. But just to show you, this was a retrospective cohort study of hospitalized patients in the United States. You could see the number is enormous, number of patients. About 6% were transfused. And after adjustments for age, gender, comorbidity, admissions, and DRG, transfusions were associated, as you could see, with a 1.7 increase or 70% increase odds for death, 90% increase odds for some infection. And again, you could see length of stay increase, and you could see that the cost per patient is enormous. And this is not the cost of blood, because we are spending about 40 billion more charges per transfused patients than for non-transfused patients. Clearly, a fraction of this can improve monitoring of safety of patients. The other issue is, as we mentioned, is the large variation in RBC transfusion. This is one data from, again, Hopkins, looking at variability of transfusion. And this slide shows you variability per procedure. Keep in mind, procedures don't transfuse patients. It is physicians who do. And the picture in terms of variability from physician to physician is no different. And the red lines are, again, the margin of variability is enormous. So where we are, we call this the transfusion confusion. And you could see on the slide that we're here over-transfusing or even under-transfusing or clearly not having any evidence for where we are. We need to get it all together, and then at the same time, we need to narrow this variability so that patients can either avoid exposure to allogeneic transfusion or, again, keep in mind, reduce their exposure. So what needs to change? Well, one of the things we need to look at is transfusion as a quality indicator. And we've asked for that time and time again. I could tell you in my institution, if you're a physician, that is one of your quality indicator. And again, we're looking at it in terms of performance. There's no question that we need to start education in medical school. But this, again, is not going to happen so quickly. So in practice, again, making blood a quality indicator or transfusion a quality indicator is necessary. I've listed others over here. But keep in mind that we can't just concentrate on the product. It's as if a diabetic patient, and we talk about diabetes as a disease that requires, again, team approach to it with multiple levels, as if the only thing we talked about was insulin. Well, diabetes, again, is a disease, and as you could see as the last bullet, is that detection, diagnosis, and proper treatment of anemia will improve patient health, well-being, and reduce healthcare costs. And the time for this is now. We're already late. So I'll finish by showing you the matrix, if you will, of patient blood management. And again, you could see that we're trying to improve the condition of the patient before they're exposed to allogeneic blood. Besides, even if a transfusion is appropriate, keep in mind it could be avoidable if we adhere to these principles that's on this slide. And one way, of course, to introduce changes that we're all talking about has to do with improved technology. And can we monitor some of the changes that patients are going through and be aided, if you will, in decision making to either reduce or avoid allogeneic transfusion and improve patient outcome. Thank you. This is a pretty big panel. Yeah. I'm glad we have enough couches, otherwise we'd probably have to sit on each other's lap. I'm going to address some questions, and I'll try to ask that we stay on time. I think the clock is a little fast, but that's okay. We're going to move, and I'm going to address you, if you don't mind, with your first name to give the impression that I'm not intimidated by any of you. So, Chuck, why don't we start with you? Do you think that there's sufficient awareness among all levels of healthcare providers, including administrators, regarding RBC overuse, the safety and cost?
I can tell you with 100% assurity that there is almost a complete absence of awareness of this. And I'm embarrassed to say I'm the editor-in-chief of the Journal of Patient Safety. We have our publisher here. We have a number of our associate editors here. And until you really brought our attention to it and others as we were looking at this over the last 6 months, we were amazed at, on one hand, the fact we aren't aware and no one's really accountable on the 4 A's we previously discussed. Very few are accountable. We aren't really able because we don't really know enough about it to make the changes, and very little action is being taken. And so, in fact, you were so wonderful about teaching us and our team, we polled a national audience. We have a very large webinar that we run every month, and we polled them and identified that this is A, a really important issue, B, we are really unaware, and I think and I'm a recovering optimist, so I see this huge opportunity of dramatically reducing costs while at the same time improving quality of care and making caregivers more astute about the entire continuum. So, and also as a cancer doctor, seeing the impact on cancer patients and the long-term impact of this, of graft versus host disease, and a number of the other things that that are the negative things over the long term, I would say, A, we are very unaware, huge opportunity, and thank you, Joe, for bringing our attention to this in this meeting, because I think we can come out of this and really start to focus on it. But B, this is a huge opportunity for accountable care, and as we really have accountable care hit and slam into gear, this is a golden opportunity to use non-invasive testing and a number of other things, an end-to-end approach to turn this cost center into a profit center for accountable care. So I think it really has that fit, but awareness is very, very low.
Thank you. Keith, I was going to ask you in terms of the risk-benefit ratio we talked about. Even with the knowledge of risks and cost of transfusion and world's transfusion guidelines, which are plenty out there, and by the way, if I may make a comment about transfusion guidelines, most of them come from the blood industry. It would sort of be very difficult to convince the CDC to follow guidelines by Lilly or other companies that produce antibiotics, for example. We still battle with the guidelines because many don't adhere to them. But what are the challenges that clinicians face in the moment when they need to decide whether to transfuse a particular patient?
Well, I think this is a very important point. And I had, about 2 years ago, I published a book called Anesthesia Emergencies, where one of the things we talked about was massive transfusion, particularly in the trauma setting. And the guidelines are very clear. And in fact, there was an article that was just published in JAMA from, I think, the January 2nd issue, where they unequivocally stated that adhering to a hemoglobin level of 7 to 8 did not cause any harm, and in fact may have improved outcome while saving many, many units of packed cells. But the big problem that we have is access to the data. In order to tolerate a lower transfusion target, you have to be able to have information about the hemoglobin level at the point of care. And that needs to come quickly. You can't send out a laboratory value and wait for 30 minutes for it to come back.
So helping in decision making.
Yeah, in order to improve your decision making, you have to have the data.
So Michael, 15 years ago, I was invited to give grand rounds at the Cleveland Clinic. And one of the physicians told me, I know what you're going to talk about, but let me tell you, we're the biggest transfusers in the nation, and we're proud of it. So
thank you.
We are now 15 years later. And the question is, again, I know that the amount of cardiac surgery that's being done at the Cleveland Clinic is enormous, and we already showed that about 20% of blood is utilized. How has practice changed since my last visit as a visiting professor?
Well, I'm pleased to say it has changed, and the driver of that change has been cardiac surgeon. As you know, Toby Cosgrove, who was chief of cardiac surgery back then, is now our CEO. And it's not just in cardiac surgery. He made this a really high priority across the health system. And really, leadership, number one, his involvement in this, his interest in it, his review of the data, really helped drive change. Two, on the technology side, this has been one of the great examples of using the EMR for us. With standardized orders, staff is held responsible and accountable, so attribution of who is in charge of the patient comes back to the staff. If their blood is given to their patient overnight, they have to sign off on those orders in the morning, and that includes the justification for the transfusion. What was the indication? And that's a standard order set. It's not 10 different things sitting out there in each department. And then really the third limb of the whole thing are scorecards. There are scorecards down to a physician level that are used and useful in terms of, and they're open, very transparent. I could go on at my desk there just now and show you the use for any given physician in the clinic. So although cardiac surgery was big, there were other big ones. I'm a surgeon. I did liver transplant. I used a lot of blood in my day. I think the whole philosophy has changed dramatically. And over the last 4 years, we've reduced overall use 30% as we look at it, adjusted per 1,000 patient days. But we've had a dramatic reduction in blood usage over the last 4 years under that leadership.
And what do you think that's done to the bottom line?
Oh, I think it has opened opportunities, as you say, to put money in elsewhere. The same time frame, I've had the opportunity to build a lot of other support things in quality and safety. But it's been a very useful example of how you can change the culture, get people to think differently, and use these same approaches as some of the other projects we drive for quality and safety too. It's been a very useful one from my perspective.
So as reducing transfusions, if you will, and again, having more resources available, what has that done to patient outcome at the clinic?
I think you are aware of the literature that's come out of the cardiac surgery group in particular, showing that there are adverse outcomes. I think you can translate that to the other populations as well. So I think it was the awareness and it was the education for a lot of the physicians. No adverse effect, and someone in certain fields, one would submit improved outcomes where we have lowered the transfusion appropriately.
Yeah. So I think, again, we could save money and yet improve patient outcome and patient safety. Howard, I was going to ask you about, with regard to patient-centered decision, which is part of the principles of patient blood management, does it make sense to have a discussion about transfusion decision during the surgical timeout for the patients undergoing operations?
So because I'm scared of you, I'll refer to you as Dr. Shander.
I don't know who that is.
Sorry.
The only reason I'm here, Howard, is because of you. I also went to University of Vermont.
I was the founder. No.
I wasn't born on February, though. That's the only.
So this is an easy one because I think it gives us an opportunity. Every day in every operating room across the United States, people are doing timeouts. And for the most part, anesthesia caregivers are passive in the process. This gives us an opportunity to be more active in the process of the timeout, where we can pose the question to our surgical colleagues, what's going to be the transfusion trigger? I think we agree on that. I think it's then imperative to document that. I think in the debrief, when we talk about what happened during the case, if we transfused blood, it's important as a communication tool and as a handoff tool that we talk about that. And then if there's a post-operative hematocrit, I think it's important to link the two back. How did we do? How did we do in relationship to that trigger that we decided on? And then if we can then close the loop, as I think you're doing, and feed that information back to the providers, I think that that's very powerful. And then one step further, as Michael knows, we contribute, as many of you do, information to an outcomes database. If we can then look at our practitioners and compare them to others to see how we're doing, and then eventually the hope is to use this outcome database to look at outcomes, I think that's a really powerful tool.
Thank you. So looking at information, and John, you've, as an institution, were the authors of the variability paper, the latest one, actually the largest one out there. The question I have to you is, what do you think are some of the barriers and drivers for some of this variability, and what can we do about that at this point?
Well, first of all, I have to acknowledge that the study looked at one epoch of care, that is intraoperative.
Right.
It really was enabled by what my colleagues have talked about, and that is the availability of a database that allowed us to look at a wide number of surgical cases and a wide number of care providers who are responsible for giving blood in the operating room. And that's a tremendously powerful tool. And the audience should also know that there are two movements in anesthesiology and perioperative medicine to bring these individual institutional databases together. One is the Anesthesia Quality Institute, and the other is the multi-center perioperative outcomes group, where databases across institutions will be brought together to look at these problems more closely. Now, in terms of the drivers of variability, the one thing our study showed was that one driver of variability was the type of surgical case. Obviously, a case that has a lot of blood loss has a higher incidence of blood transfusion. The other is that, unlike other studies that have looked at blood transfusion needs, perhaps in the ICU, is that the operating room is a very dynamic place, and you have ongoing blood loss. And so you many times cannot make the decision about whether to transfuse or not based on a number. There's lots of other things going on. You have evaporative fluid losses, you have the administration of other crystalloid, non-blood containing fluids. And really, in addition to not having timely information on blood counts, we really have variable information on actual total blood volume. The other is one of culture. And I'm talking about culture that goes right down to the individual. Remember, surgeons are different than anesthesiologists. We come at the problem from two different angles. A surgeon is looking at risk of death from a knife. It's an outcome-based view, and he's comparing risks of dying from blood loss, dying from a surgical intervention. And when you look at the real risk of blood transfusions compared to that, he sees that as minimal. And so there's an individual in the room that perhaps wants to give blood more than the other. The anesthesiologist, on the other hand, is looking at balance of organ function and is satisfied, I think, in many cases, not to give blood in those situations. Remember, the operating room is the only place where you have two captains of the ship working, and that can in itself lead to variability. The one nice thing our study showed is that in teams, and cardiac surgery being one of them, where you have consistent surgeons and consistent anesthesiologists, the transfusion trigger for both was the lowest in our study.
Thank you. I think another point, I don't know, I was given this maybe because I have to keep you in line if there's some issues that come up, but I think that one of the issues in terms of patient blood management is to alert us that doing business as usual is not what's going to be the future. And I think a few of you mentioned the issue of ongoing blood loss in the operating room as business as usual, and I think we're starting to look at that and seeing where we can avert that and not accept that as business as usual. Again, conserving the patient's own blood is one of the activities in terms of patient blood management. And as a breakout sessions, we have one case where we actually return the patient's own blood to the patient, again avoiding allogeneic transfusion in this particular trauma case. So I'll move on to Dr. AWadhi and ask you, you have experience, clearly more global experience in terms of transfusion and how they're done in different parts of the world, and maybe can you share that with us at this point, how you see the differences?
Yes, sir. First of all, I would like to thank everyone who helped me in order to come to present between all that science here in that great summit. And I'm from Egypt. We're having a great problem that in our practice of blood transfusion, it differs from what you're having here. Not for lack of knowledge, but mainly for lack of resources. In my study, I have classified the two groups of patients. One is mainly depending upon the estimated blood loss and the lab hemoglobin in order to replace blood, and the other on continuous non-invasive hemoglobin monitoring. The main issues in the lab group is 3 issues. One is the delay time from drawing the sample and receiving the lab. We don't have a device nearby in the operating room in order to tell us how we are going now. The second is feeling of competency and controlling the whole situation in the room. The third is the cost. For the issue of delay, I have got a great criticism during STA discussion that they told me, if you have a device inside your operating room to tell you the hemoglobin, will you lose the advantage of continuous monitoring? I told them so simply, first of all, we are a great hospital in the whole Middle East, and we don't have that device in each room. And second, we will lose what's advantage of trending that continuous monitoring giving us. With so little example, all clinicians, all anesthesiologists will detect it. When you see the wave of invasive blood pressure monitoring beat to beat is continuously different in your self-confidence than an intermittent 3 or 5 minutes feeling. So the continuous trending, going up and going down with the bleeding, going up and going down, you feel very competent. And this makes us to the second issue is competency. Competency will make you judge every clinical evidence with numbers and with data you have in order to take the decision, start now or stop now. And the last issue was the cost. In my study, I find I can decrease the blood transfusion units number from 1.9 from the lab group to just 1 in the continuous non-pressure Massimo group, in the Massimo group. Multiplying this by any way for the cost of each unit, you will find it so heroic for 100 or 1,000 patients.
Thank you. So again, the technology is showing cost effectiveness, if you will, not
yes,
sort of
sir,
in a generic way. And I think that in developing countries, one of the issues with laboratories...
We are in urgent need of this technology. I think more than other countries that have other devices in order to tell them where to stop and where to start transfusion. We are in urgent need for that technology.
So the non-invasive measurements, which are again a dry laboratory, if you will, where you don't need the reagents and all the equipment, is something that can be implemented in countries where, again, the economies are not as prosperous.
And it will be of a great effect.
Absolutely. Thank you.
Thanks.
Well, not last, but Tim, you've had clearly a career that's built around patient safety and looking at monitoring, if you will, of outcomes, but also looking at transfusion as an indicator. Could you give us a little talk about that?
The proposal that blood transfusions should be regarded as a quality indicator rather than simply an effective therapeutic intervention is based on a conundrum that you've outlined nicely, with the observation that we think blood saves lives. We're pretty sure it has a benefit, but you can't quantitate that benefit in a bedside discussion with the patient. We would all be hard-pressed to design a clinical trial that could prove the principle that blood transfusions save lives or provide any benefit to the satisfaction of the FDA, for example. And yet, we poorly understand the benefit in terms of articulating it to the patient, but we understand exactly what the risks are. There's a long list of them, and we can quantitate those for the patient in informed consent, the known risks of blood, and we also have unknown risks of blood, such as emerging pathogens. We all know the story of the HIV situation 30 years ago. More recent examples of this would be the West Nile virus and so forth. So it's the principle of emerging pathogens that has led to the blood shield laws, where state legislatures have passed laws that blood is a medical service rather than a product, because we cannot be held legally liable for the safety of a blood product. We cannot warrant its safety because it's inherently dangerous and inherently risky. So this is why it's difficult to have an informed consent conversation with the patient, trying to articulate and let them reassure them if and when we decide to transfuse, it's because in our own opinion, the benefit outweighs these risks. And the heart of this discussion is the founding principle of blood management, which is the appropriate use of blood and blood components with the goal of minimizing their use. And seemingly that's a radical thing to say, but it's very patient-friendly. I've never yet met a patient who's enthusiastic about getting a blood transfusion, and in addition to running a blood bank for 30 years, as a hematologist-oncologist for 25 years, I was hanging blood at the bedside. So less is more, and so why not have blood transfusion outcomes, the blood we're transfusing for a medical or surgical service line or department, be a quality indicator in the same way we look at mortality or 30-day readmission rates or perioperative infections as measures of quality. Why not look at transfusion outcomes? And with knowledge comes power, because if a service chief knows of the 30 faculty members in their service line or department who are the outliers, that becomes part of the one-on-one yearly discussion with them, and they can only so many years in a row make the case that their patients are sicker than everybody else's, and that's why they're transfusing more blood. So that's why I'm in favor of regarding blood transfusions as a quality indicator where less is more.
Thank you, Tim. Going back, Chuck, to you so that you don't get bored all the way at the end of this huge couch. Talking about the issues of indicator, the question is, how do you think that the Joint Commission blood measures, as well as the Joint Commission and AMA identification of red blood cells, top 5 overuse procedures, will change hospitals in terms of the approach to RBC transfusions?
Well, you know, I think our hospital leaders, and I think those that are in the audience would agree with me, that they're so overwhelmed right now with the biggest tectonic shift in their payment system that probably they'll ever encounter. And they have, and as we heard from Rick AWadhi, you know, there are these competing issues. I think that very few are aware, Ari, and I think, you know, if I sat down, I think all of us have to go back and we have to pledge to really do things. And I'm going to go back and talk to CEOs, and I'm going to say, did you know that the most frequent procedure in a hospital today is a blood transfusion? Did you know that a blood transfusion is like an organ transplant and carries certain significant risks? Did you know that you could probably save $1 million a year if you were more careful and had an end-to-end approach at blood transfusions? Did you know that your patients would be much more grateful of your sensitivity of these risks if you had everybody educated about it? And did you know there's a huge opportunity for you today in accountable care to do that? And then I would probably share a story like the one Joe and I were at a recent meeting, a prestigious meeting in New York City, and I introduced him to a physician who recently had a miscarriage, and she had a blood transfusion that she knew she didn't need. And she talked to her doctor about it, and she was as upset about the insult on injury of losing a child and was thinking about coming here, and she's a former White House intern and a physician. And she said, we need to know about this, and we don't know about this. So I think, Ari, as much as I think we need to be able to tell those in the C-suite, and we didn't define the C-suite as with the chief officers of a hospital and the CEO and the boards of directors. We have a non-clinical board member here, a wonderful representative of that group. They need to know that, and they don't need to know a lot of clinical detail to know that this is a moral imperative. This is a huge opportunity, and I think that's what we got to go back and tell people. It's just those factoids that are so important. Final point is that the biggest group of overuse are in people that have 1 to 3 units. And what you had taught us is that if we knew ahead of time and we had tested them and given them iron, a significant proportion would never need a transplant in the first place. So that's re-engineering our care and recognizing that this is an opportunity. So I think, you know, I don't think that those in the C-suite or even the safety officers are aware of the sentinel event issue until a meeting like this puts attention on it.
Thank you. I think that's a very important point, and I think Tim, myself, and others have been, over the years, working with the idea that anemia, which is the disease that ends up being the biggest threat in terms of transfusion, is ignored. As a matter of fact, Tim, I think, published an article called Anemia as an Innocent Bystander. Well, it's no longer an innocent bystander, and we keep ignoring it despite the fact that there is growing data showing that anemia in itself is an independent risk factor for patients, especially those for going for surgery, non-cardiac surgery as well as cardiac surgery. So I think taking the step back and, again, looking at the patient rather than the product is very important. Just a quick follow-up. In your opinion, what other organizations do you think we need at our side to make these changes or to get the information out there, but also translate the information into action?
Well, I think we've got great educational organizations like the National Patient Safety Foundation. We have some board members that are here. I think our societies, our medical societies are a huge opportunity. American College of Surgeons and the Choosing Wisely campaign that not only will address testing, but I'm really proud of physicians stepping up and saying, you know, overuse enough. We really need to get involved in that. And I think there's a growing group that are doing that. But, you know, I think meetings like this, us all going back to the meetings and the organizations that we work with and the societies we work with, it's about the movement. It's not a meeting, it's a movement. Well, a movement has spread, and Peter did a wonderful job this morning describing how movements happen. And I think we all need to go back and say, hey, what role could I play to focus on this? And again, holy grail, we can drop direct costs, indirect costs, patient harm, improve our flow, and be better doctors. There aren't that many great opportunities like that today. So I think the societies, but I think the patient safety groups, and also I think CMS. You know, I think CMS and the big payers. I'm going to go back to the big employers, and I'll make a pledge today to make sure that this issue is an indicator that the large employers will require of those centers of excellence where they're going to move big blocks of paying patients. That's my pledge, to go back and say this has got to be an issue, because it's clear.
Thank you. So again, talking about momentum and getting people involved as well as organizations, just to point to everybody is that in 2010, the World Health Assembly, in their resolution 63.12, again recommended all the things we're talking about in terms of patient blood management taking on a global event rather than just a local event in different countries. But since then, the WHO has moved back into looking at blood safety and has sort of dropped this initiative, if you will. And I think we need to see that again revived. Last year in June, Department of Health and Human Services, the Advisory Committee on Blood Safety and Availability, actually addressed patient safety through issues that we're discussing in terms of patient blood management, and made the recommendations, both to CMS and other organizations, that we have demonstration projects in each study, just like the one that was discussed earlier today in terms of critical care, that we have demonstration studies or projects in terms of patient blood management where we can actually, again, save resources, translate them to other areas of safety, yet improve patient outcomes. So I think we need to revive these because they're on paper, but we need to translate them into action.
And I think both Ed Kelly, who did a marvelous job yesterday, and Thomas Seltner are both personally interested and dedicated in this, and I will be willing to bet that WHO will be coming back to us.
So again, Keith, as we move down the line, and thank you, Chuck, given that basic tenet of effective blood management is patient-centered decision-making, and I know that that's an area of interest for you, what tools do you teach others to use and use yourself in order to improve the appropriateness of either transfusion as well as those given as far as information to patients?
Well, again, I think what it comes down to is having the right kind of data at the right time. I think we have to teach the guidelines. I think we have to make others aware of the guidelines that are already out there. A lot of this work has been done. Again, there are articles that are out there this week, but a lot of this information is certainly months old, if not years old. And I think we need to teach the appropriate guidelines. At the same time, I think we need to incorporate appropriate hemoglobin monitoring at the point of care. And the advantage of using these lower transfusion triggers is undisputed. But as I've mentioned before, and as I like to say to the people I'm working with, you have to have the courage to adhere to them. And if you have point of care monitoring where you can get the hemoglobin level now, it becomes much easier to adhere to a lower transfusion trigger than if you have ongoing blood loss and you know that you're going to have to send that lab out and wait 45 minutes or more for it to come back. So I think, again, I think you need to individualize the transfusion decision to each patient, to the coexisting diseases that they have. I think you need to individualize it to the type of surgery. I already mentioned trauma surgery, for example, in massive transfusion. In my day job, I'm a neurosurgical anesthesiologist. The blood loss there is usually a lot slower, and you have time to be more thoughtful about it. And that's where you get into that 1 to 3 units of transfusion and the potential for overuse. And you need to have the right data.
So 15 years ago, Mike, I'm sorry, I already told you that.
Yeah, I got.
But I just would move on. But thank you, Keith. I think one of the initiatives that I know that the clinic is looking at is, again, techniques to preserve blood intraoperatively, but also to address anemia in the surgical population. Can you comment on that?
Yeah. I think one of the other initiatives that's gone into place is a whole blood management program, and I know you've been a big champion of that. And I think that's about optimizing the patients. That's about, can you delay, if they are anemic, can you fix it? Can you delay their surgery for a week, a month, whatever, just to optimize conditions? That program is in fact run by our pre-operative evaluation group, the hospitalist service. And I think, just as a little aside, let's not forget the medical folks in transfusion. We focus a lot surgically up and down here, and certainly a significant amount of our blood use as an organization does occur on the medical front as well. And I think we shouldn't lose track of that. So I think it is having management assessments and management algorithms in place to assess and to treat the anemic patient have become an important part of what we do. And then you do get the things that happen in hospital. And I think for an example, our ICUs have gone to small volume blood tubes. And we reckon we'll probably cut back 25 to 30% the volume of blood we send to the lab. So hospital-induced anemia is a very hot topic with us at the moment. And looking across the whole health system, a significant percentage of patients admitted to hospital are anemic if they're in for more than 5 days. So I think we need to be looking critically at what do we do to reduce those kind of activities. So a blood management program is important in terms of optimizing patients preoperatively. Critically looking at medical patients, I think, is important. And then some of the things we can do intraoperatively. Sure, I was a big cell saver user in my liver transplant life. I think that technology has got a whole lot better. And I think how one manages those intraoperative issues. And I trust my anesthesiologist, you guys, on the antifibrinolytics and things as appropriate. And that was part of my life and clearly part of the cardiac anesthesiologist's life too.
And you should trust us. We're doctors.
It's a team. But that's, you know, I think we've come a long way in the team approach to these patients. And that's really important.
Absolutely. And I think you make an excellent point because in light of everything we talk about catastrophic medical errors. But there are a lot of medical errors, if you will, which are not catastrophic. One of them, of course, is the issue of anemia in hospitalized patients, which you addressed. And about 30 to 40% of surgical patients admitted to hospitals are admitted anemic, undergoing surgery, where they're going to be transfused because that's going to be the #1 indicator. What's interesting, on discharge, close to 90% of patients undergoing surgery have anemia, which is not addressed. In addition to that, we aggravate the situation. When you enter in the hospital, there's something called phlebotomy. We do tests on patients every morning. We say actually the most common cause for phlebotomy, meaning drawing bloods on patients in US hospitals, is sunrise.
Yep.
People go out and collect blood. And what happens is we get the same results over and over again, except for one, which is patients' hemoglobin. We're aggravating the situation in patients. We're causing, if you will, a medical error, which is not catastrophic, so everybody ignores that. So I think that the clinics paying attention to this area, which is a rising concern, will save resources. And again, keep in mind, all we're interested is making sure that our patients not only do well, but have improvement in their health, their well-being. Anemia is one of those diseases that clearly interrupts well-being.
It's a big culture change, and I think it's one of the lessons with my residents. I still operate a bit, and I say, don't you dare draw daily labs on these patients. They don't need it. What are you going to do differently? And I think it is exceedingly widespread, but it's a culture, and then it's the whole educational approach to it. We've got to change.
Agree. So thank you, Michael. Howard, I was going to ask you, how do you see continuous trends in hemoglobin, I guess the contribution of technology, helping and assess blood loss, and also helping in terms of the correct transfusion decision? And I know we've all used the word trigger, which is, again, we're not going to raise the whole political issues with guns right now, but a transfusion should never be a trigger. It should be a complex medical decision. And I guess, how do you incorporate the information you get from technology, determining when is the right time, if you will, to intervene, or how to, again, avert a transfusion under the situation?
So, unlike what we've already discussed here, what worries me, mainly because in talking to you and talking to other people in the audience and talking to my colleagues back at my institution and seeing cases come through our quality committee, I'm desperately worried about the other side, which is the underuse of blood. And the appropriate, when is it appropriate to transfuse the patient? Are we waiting too long? And I think in the perioperative space particularly, but probably other spaces within the hospital, continuous monitoring of hemoglobin will help let us intervene more appropriately sooner, and I think we'll see an outcome variable. Now that's different than, I mean, I am sure, having listened to everything that's been said over the past 2 days, that this audience and we will all be charged about going back to our institutions and doing something about the overuse of blood products. That doesn't concern me. It's the other piece that I worry about. And having not had an opportunity to yet use this technology, I'm excited about it, and you know, we have plans to use that. And it's, in my institution, when thinking about installing technology like this, we're a small institution. This requires a significant amount of change management. This will, if we go this route, this will to some extent paralyze us from doing some other things for a while. So it's a big decision for us. I think it's a worthy decision for us, but it is a big decision for us. And I think, as you know, the other thing that concerns me is, you know, if Peter Provenos can call up an electronic medical manufacturer, electronic medical record manufacturer, and pretty much not get the time of day from them, how do I incorporate those measurements in my electronic medical record? And this is another thing we need to commit ourselves. Those barriers must be broken down. So I know I sort of diverged from the question itself, but I think those are the things, when I look at technology, it's not just the technology, it's not just the value that could help us care for the patients, but unless we can get it into our record, unless we can get it into the databases, unless we can then look at large sets of data, how are we ever going to make decisions about the value equation? So that's my thoughts about this.
So I think it's important for us to, again, I think the technology allows us not to get answers, but to get information.
Absolutely.
And each time we have to make a decision, again, the more information we have that's real time, and again, is available, I think helps in terms of making a decision, whether it's trying to avert a situation where transfusion can help versus, again, the other, which is the overuse issue. I agree. Again, I think that when you're worried about that other side, if you will, in many ways, I see that as bad clinical decision rather than part of the overuse issue, which, again, with information, real-time information, we'll be able to avert. So thank you, Howard. John, you're again up here, and we talked about technology, we talked about some of the leadership issues, and back to the practice issue, I guess, is what do you see as other modalities that, other than RBC transfusion, to treat anemia during the surgical population, during the surgical procedure, or even in the total perioperative period?
Well, there are a number of things that can be done, and I think you introduced the topic earlier of a blood management program, and that's extremely important. First of all, it empowers individuals within the organization to focus in on this problem and to help others find solutions to it, introduce new ideas on how to care for these patients. Now, there are a number of things that we have available to us now. Surgery has advanced over the decades. More microsurgical techniques are available, minimally invasive surgery, so the disruption of tissue is far less, and therefore bleeding and blood loss is less. Other concepts that have been introduced today about phlebotomy. You know, one thing we ought to challenge ourselves for is perhaps not just in the ICU, but maybe all of our hospitals should say, we're all going to use micro-sized tubes. What is the real benefit for using large-sized tubes? Sensors now are dealing with small volume of fluids. There are a number of things, including perioperative iron, erythropoietin, that can be used to treat right through the surgical course to address the issue of postoperative and discharge anemia. Use of hemostatic agents to control blood loss. So there's a whole panoply, really, of opportunities that can be used. But it really takes resources. It takes resources to go out and educate the various stakeholders, the individuals who are making the decisions. And I come back to the blood management program as being a vital investment. One of the side findings in our study, which is purely observational, comes back to the culture. It's a knee-jerk reflex to order a type and cross or a type and screen for every kind of surgical operation. It's part of the training. We looked at one surgical type, a ventriculoperitoneal shunt. We do about 500 of them over the last 3 years. 50% of those patients had a type and screen or a type and cross. Not one of those patients ever got transfused. Now, you can estimate the cost savings of that, and I will guarantee that that cost savings of that one finding will pay for your blood management program in your hospital. So earlier today, we talked about shifting the cost from one program to another to allow us to make advances and to innovate in new programs. Here's a real example of where, in my institution, and I'm sure others here, we've made that investment. We've paid up front to support individuals to have a blood management program, and it's already paying off within a year of its inception.
So the gamut of things that are available is not just one or two things. I think that there is a lot out there that needs to be harnessed. Unfortunately, again, it requires change in culture, the education, and again, trying to divert the attention from transfusion to these other elements. I think that's important. And going back to the point that was made before, our colleagues in internal medicine now are the next target, if you will, because we've been able to contain a lot of this in the surgical population, whether, again, with the help of technology or help in change of practice, and also showing the benefits in terms of resource utilization. I think that now the second, and we already have data out there both from Europe as well as the United States, that in this particular arena, internal medicine and oncology, that patient blood management still has a role. So, thank you. In the last few minutes that we have, Dr. AWadhi, just if you could share with us your experience that you just had an award for in terms of how to utilize some of this technology.
Again, sir, that's the same way we are all talking about. The decision of blood transfusion is not just a matter of solid number. It's a matter of clinical sense. And from the slide you have shown, sir, between the variability between the practicing of physicians for blood transfusion, it's very vary. Despite most of them at the same center, maybe having the same professor, educated at the same university, but still there is a personalized matter, a great matter in taking the decision of starting blood transfusion here immediately now. So the whole issue in order to, when you took the decision in order to start blood transfusion or postpone it, in order to feel self-secured for your patient, self-secured for yourself. I have to start it now. I just need, as you, sir, said, I just need more information, but I don't need an answer. More information from more technology will facilitate the information, the answer for me.
Thank you. So we're almost at the goal here. So first on goal, Tim. I guess you mentioned it before that those who actually have the information in transfusion medicine are probably the lowest transfusers, and those who have very little information are the highest transfusers, at least from data that we have out there that's been published. Can you comment on the role, I guess, of the laboratory transfusion medicine in helping promote patient blood management?
Well, one of the problems with laboratory-based utilization review retrospectively is how could discussing a handful of cases at the transfusion committee every year improve transfusion practices at an institution like Stanford that transfuses 40,000 red cells, or Hopkins that transfuses 70,000, or the Cleveland Clinic that's somewhere north of 110,000. And my bias is it's a lot of work and we're just going through the motions. And where technology has leveraged this is concurrent review. And so with the electronic medical records and the physician computer order entry, we've implemented, as I know others have, best practices alert, where you've got the pop-ups reminding people about best practices and level 1 evidence. But I think even more effectively is an acknowledgement section where we ask them to put down a reason why they're transfusing. And we give it's a multiple choice: hemoglobin level, vital signs, bleeding, other. It's voluntary. I think it should be required. But you're getting information, but most importantly, you're asking them to think twice about the decision to transfuse, and they know they're being watched. And I think that that is responsible, although I don't have the data to nail this yet, but for a pretty profound reduction in utilization at our hospital. And now, I think to satisfy the mandate from regulatory accreditation agencies that we do peer review processes, that's where the peer performance review committees come in, where we give them the data on the faculty in their section, and they can choose the outliers for case-by-case peer review to satisfy regulatory requirements for that aspect. So I think it's a combination of both, but I think far more effectively is decision by decision, making sure the treating physician, when they're ordering the blood product, knows they're being watched and they're thinking twice about it.
The GPS principle, Joe. Well, we're at the end of this session. Now, this is a postprandial panel, so thank you for staying awake, and thank the panel members. And again, we're moving on to the next affair. Michael?